Okay.
3, 2, 1.
Hi, good evening, everyone. Welcome back to another Wednesday webinar with me. And today I have my colleague from Sunway Medical Center, Dr. Margaret LEOW. And she is actually plastic surgeon who funnily is not so interested in aesthetic medicine as I would think she would be. She's more into reconstruction work, and all her surgery seems to be like 14, 15 hours. Every time I see Margaret, she's like half dead, looking for food. And she's doing, what kind of surgery are those actually? Can you tell us more?
Oh, I think Jeff will tell you more about it
Yeah, that's
next
right.
week.
Jeff is going to come in. But
Yeah.
just briefly,
So
what
it's
are those?
similar. It's reconstructive work where it's head and neck cancers or lower limb or some cancer reconstruction where we need to do a free flap, microsurgery. So it takes a long time.
Yeah, the reason I'm asking you is because a lot of people have this idea that plastic surgeons, aesthetic surgeons, always looking into beauty of a woman or a man, it doesn't matter. But actually, you start off as something else, right?
We always start off with reconstruction. That's our main base. And only if you get good at it, then you move to aesthetics. Unfortunately, most people just want to do aesthetics because this is the easy thing to do, less risk, less work, and more money.
Yeah, and less hours, right? Standing
Yeah.
13, 14 hours for this reconstruction.
Yeah.
And I also want to ask you about this. I wish I didn't know myself that actually plastic surgeons do handwork.
Yes. Actually, we cover everything from head to toe. Anywhere that you are covered by skin, we do. So we overlap with everybody under the sun. So yeah, we do a lot of hand. It's a big part of our training, but not everybody wants to do hand. And here in Malaysia and also in Singapore, there are hand surgeons, and you can go to do hand either through the orthopedic route or through the plastic surgery route. There is a retired hand surgeon that started Selayang hand unit, was a plastic surgeon.
I see. Okay, without further ado, we go into your burn. And again, I think not many people know that plastic surgeons handle burns.
Yeah, because we do a lot of wounds and we are specialized in the surgery of skin. So therefore, burns should come under us, I think. I know. General surgeons can do it too. Whoever does it better should be the one to do it. That's the way I feel.
So plastic surgery actually is skin surgery. Is that what you're saying?
Yes.
Oh, I see. So anything related to skin comes under plastic surgery.
Yes. It's like how, there's neurology and neurosurgery, and there's nephrology and urology, something like that. So it's dermatology and plastic surgery.
Oh, very interesting. I never saw it that way. Yes, I never saw it that it's all related to skin. Therefore, that's why reconstruction, trauma sometimes, burn,
cancers,
and hands.
Yes.
Okay, let's see what you have to share with us.
Okay. All right. So share screen. Managing buttons. Share. Oh, it's moved over. Can see?
Yes, very well.
Yeah. Okay. Right. So I will. Thank you very much, Dr. Betty, for inviting me.
Please call me Betty, please.
Okay. For inviting me to share my talk on how to manage burns. And just wanted to say that I have nothing to declare. I'm not affiliated with any company, any wound company, any dressing company, although it would be nice to have shares in like 3M or something like that, but I don't. Okay. So this is the outline of my talk. I'm going to really race through pathophysiology because that's the boring bit, but some people, you need to understand it a bit to know how to manage it, which is why I put it in there. Okay, so this is the estimate of the number of people who get burnt. It's roughly about this, and it's mostly children who get burnt. It mostly occurs in the house, and it's mostly scalds. Okay. So how to classify burns, you do it in 3 ways. What it is due to, what a burn is due to, the depth of a burn, and the size of a burn. So when you're referring a burn to me, I need to know the size of a burn and the depth of the burn and the main things about the patient. Okay, so this is the skin, and it's divided to epidermis and dermis and the layers. So this is not an anatomy lecture, but suffice to know that depending on which layer is burnt, then you will see it goes from a superficial burn to a partial thickness burn, and they are divided then into superficial, partial, mid-dermal layer, and then deep partial, and then full thickness. Okay, so this is something you need to know. So then burns are caused by, the commonest cause is thermal related. So it's either hot or the lack of heat. So frostbite is from lack of heat, and that also causes an injury, which is like a burn. Okay. So then there's all these other things like chemical burn, electrical burn, and then what people don't realize is that when you fall and you skid on the road from bicycle or motorbike, which is very common in Malaysia, you get a friction burn, which is the physical one. Okay. And then, of course, all the patients that go for radiotherapy, some of the oncologists refer to me post-radiotherapy burns. So then you have to know that this is what we call a superficial burn, what a lot of books call first degree. Plastic surgeons don't like, and this is not burns. The Burn Society don't like the word first degree, second degree, third degree, because it doesn't tell you what it is. So it is known as a superficial burn, okay? And it is like this, it's a sunburn. So especially if you're fair and you go into the sun without protection and without sunblock, and you're going to get burnt. And I've had this myself a few times. And then after that, if you go deeper into the dermis, to the upper layer of the dermis, then it's a superficial partial thickness burn. And if you go deeper, then it's a mixed depth, mid depth. And then the deeper you go, then it's a deep partial thickness burn. And then you can see parts of this. This is a partial thickness burn. So it's lost the top layer, and it's light pink. It's very moist. It's very oozy, and it's very painful. And then when you've burned through all the layers of the skin, you get a full thickness burn, okay? And this is what it looks like. It can be white, okay? And then this part here is deep partial thickness. And further along there, you can see some maybe mid-depth partial thickness burn. And this is another example of a full thickness burn where it is charred and black from the flame. Okay, so usually there is no pain because all the nerve endings are burnt. So patients have less pain with this than in a superficial partial thickness burn. Okay, so then you next have to tell me the size, and how you estimate the size is the easiest way is by the palm size, but you can only use this if you have a small area of burn. So it's not your hand, okay? It is the patient's hand, okay? The patient's palm size. So you use that to either estimate a very small, like 1 to 2%, 3% burn, Or if it's a big burn, you just count the area which is not burned and then 100 minus that. Then the next one is the Wallace rule of nines. So your body is divided into 9. So whole upper limb is 9. So the front of it is 4.5. The back of it is 4.5. A whole lower limb, the front is the whole front of a lower limb is 9%. The whole back is 9%. The whole actual lower limb circumferentially is one lower limb is 18%. And then the trunk is 18%. And that's the way to calculate. Another easy way. But the most accurate way is you use the Lund and Browder chart. And this is for adults and this is for children. And it's about up to the age of 10. I mean, the problem is our children are now of varying sizes. Some of them are really big and some of them are still quite small and scrawny depending on how much they eat. So you have to estimate and guess. So the reason being is because in a child, the head is quite big and the limbs are very small and the opposite direction for an adult. So you've got to draw roughly the area that you see which is burned on the chart and calculate from there to make it more accurate estimation. Okay, so then the reason why you need to be accurate in estimating burn size is because you need to know when to refer. Now, a major burn is anything that is 30% and above. 25% a burn unit will also take, okay? But anything above 15% for an adult needs resuscitation. Anything more than 10% for a child needs resuscitation. So therefore, they have to go to a hospital. It may not be a burn unit, but a hospital that can manage a burn. And then these are the other things that you should refer to, special areas, and then significant electrical burn, not just, you know, your finger or something like that. A significant chemical burn, you know, inhalational, and all these other things. Like if it was a car accident and they got smashed up and had fractured pelvis, as well as a burn from being trapped under a motorcycle, or if let's say it was a diabetic, hypertensive, elderly patient that got scalded, you still have to admit because, you know, all their medical problems will make them worse. And of course, if you suspect non-accidental injuries, which not just happens in children, you have to look for them in people of low IQ and geriatric patients as well. Okay, so now, before I move on, anybody wants to ask any questions about any of that first?
Oh, we'll take questions at the end.
At the end? Okay,
yeah,
fine.
that's right.
Right. Okay. So then
Okay, go back to your previous slide. I still cannot catch the joke.
He's dead. He's charmed.
Okay. Okay. Okay.
But I like these things because they're funny.
Okay. Oh my God. I'm
So
slow today.
the first thing that's really important in a burn is first aid. And you'd be amazed at how badly we do this. Okay. So, and I think the other thing is education, which is what we are doing now, and prevention. Okay. So these are some things that some other countries have all these educational ads and in schools. And I don't know, because I don't go to schools because I have no kids. So I don't know whether they have them, but I think this is really crucial. You know, it starts in the house, it starts in school. Okay, because everywhere I go, it is so badly managed. Okay. And this one is standard in Australia. You stop, drop, and roll. Okay. So first aid, you have to stop the burning process. Okay. When you got scalded, when you have a flash flame, when, you know, hot oil poured on you, or you need to stop the burning process. The only difference is with the one of this physical friction burn, because that one, there's nothing there anymore. Okay, so you need to cool it, and the best way is with running water, and you should do it for the ideal is 20 minutes, and then you should go to a facility that can look after you, be it a GP, if it's a small place or a hospital, it doesn't matter. But no ice, don't put ice on it, because then you cause the other extreme and a frostbite and further burn injury. Okay, so there are other things that can be used. I think GP clinics sometimes have them. I think firemen store them, and some first aid kits have them, like burn shield if you don't have water around. You know, these are some of the other things that can be used to help cool a burn. Okay, so let's say you're coming from Banting or somewhere, you know, so if it's just a hand, then you just get a bucket of water and you dunk your whole hand in the journey to, I don't know, Klang Hospital, and then from there to wherever, UH or Shah Alam or wherever. Okay, so I've seen so many burns where they've put all these things. They've put butter on them, they've put ketchup on them, they've put, yes, they've even put you know, the betel nut, the alkali on them, and made it worse. So some chemistry teacher thought she was so clever.
Toothpaste.
Yes, toothpaste. Yes, some chemistry teacher thought she was very clever. She had an acid burn and she poured alkali on it. So on top of the chemical burn, she then had a thermal reaction and had thermal burn to add to that.
Oh my God.
Okay, so yeah, I've seen everything lah. I've seen everything put on. So no, no, no. And then after that, it's ATLS. Of course, you know, if all you have is a one cigarette burn, you don't need ATLS. Or, you know, you touch some jaw stick or something, you don't need that. But in general,
what's ATLS again?
Advanced Trauma Life Support.
Oh, I see. Okay.
Okay, so maybe you can get an emergency physician one day to give you a talk on ATLS.
Oh, yes.
I think it's very important.
Yes, okay.
But the ATLS books are also wrong, because they also go first degree, second degree, third degree. So that one you ignore.
Okay.
Okay, so but you look at the ATLS teaches you airway, breathing, circulation, and then disability, exposure, etc. So A, B, C, D, E. So the main thing is you first of all look at airway. Going on the history, you want to know whether the patient was a flash flame burn, was it in an enclosed room, and then you need to know whether there's any inhalational injury. Because if there is, and then everything starts to swell up, you're going to block off your airway, and then they won't be able to breathe and they die. Okay, so some of these things are important. If it's a big enough burn, then you need to assess how big it is, whether it's circumferential. Remove the clothing because it may be trapping the heat. But you also need to prevent hypothermia, because all our emergency departments are freezing cold. Okay, so you cool the part that needs to be cooled and you warm the rest of the patient. Then you need to set your line, you give your fluids. Also, you need to weigh the patient, because all your drugs depend on the weight of the patient. And if it's somebody like you and me who know how much they weigh roughly, you know, not gonna matter one kilo either way. Okay, whereas if it's a little child, a little baby who weighs about 2 kilos, 1 kilo, when you're giving analgesia, all these things makes a difference. When you're giving fluids, all these things make a difference. So you need to know. Immediately, you need to remove all jewelry. If you look at this, the thing that's so wrong is the ring was not removed. Okay, if you have a burn to the face and the ear is involved, you need to remove all the stud earrings before the ear swells up and the earring gets buried in it. Okay, and causes a problem. And then you may need to do an escharotomy like this, or a fasciotomy if there's a crush injury. Sorry, I'll go back there. Okay, and the analgesia of choice is intravenous morphine. Don't mess around. If it's a big burn, don't waste time with paracetamol, with aspirin, with pethidine and stuff like that. IV morphine. Okay, IV morphine you titrate.
On the scale of 0 to 10, what is the pain like?
It is 10. So for those of you women who have had babies and haven't had an epidural,
Or like
the
me.
pain
Okay.
that you get is like 10 and then it goes down and it
Yes.
comes again and it goes down. A burn is constant 10
10.
all the time. Okay, for the men who've had renal colic, that pain constantly, it's 10 constant.
Kick in the, you know what, right?
Yeah,
Yeah.
yeah, constant. It doesn't go away. So it's really painful, okay? Really painful. Okay, so then just a brief word on pathophysiology, and then I'll run through the rest of it. So there's local and there's systemic. The reason why you need to know if it's more than 30%, then it affects the whole body because of all the cytokines that's released. Okay, so you don't need to know half of this stuff. Just know that in a big burn, you need to go to a burn unit. Okay, a proper burn unit. So then there's this thing called Jackson's burn zones. So the area mostly in the middle, the orange one, is the dead bit. Okay, and then surrounding it, there's a zone of stasis where it can go either way. Okay, so if you look after your burn well, if you do the correct dressing, if let's say they are an elderly patient and you control their blood pressure, you control their diabetes, then the zone of stasis will improve and get better. But if you don't, if your burn wound becomes desiccated, it got exposed, infection got into it, then that zone of stasis will change and become dead and become a zone of coagulation. So you can see it becomes wider and deeper. Okay, so wider this way and deeper. And then your zone of hyperemia, where there's just inflammation starting to settle in, will then become a zone of stasis, and then this whole thing will go out. And I've seen that myself in an actual patient when I was working in the burn unit in Toronto. So we're not talking about conversion with this. We're talking about a burn converting to becoming bigger and deeper. So from a partial thickness burn, it becomes a deep to nearly a full thickness burn when it's not looked after. So that's why I say first aid is very important. Proper burn care is very important. If you don't know how to look after it, don't look after it and cause more harm. Okay, so I'm going to run through this thing because you just have to know that it affects every system in your body, not for the little burns where you just, got a cigarette burn on your hand, or a little fish, frying fish, that time the oil splash on you. This is bigger burn. It affects your heart, your blood vessels, the fluid translocation to third space, your lungs. It gives you ARDS, you get bronchoconstriction. It affects your whole gut integrities, which is why you get the Curling's ulcer. It increases your basal metabolic rate to 3 times. So burn patients lose a lot of weight because they cannot eat enough. And then you get splanchnic hypoperfusion and all this stuff. Okay. And then
can
your
you go back to
immune.
the previous slide and just explain to me, especially, what is a Curling's ulcer?
Okay, so there is Cushing's ulcer for those neurological problems, and then curling has an ulcer. It's like a peptic ulcer associated with burns.
I
So
see.
Cushing's ulcer is an ulcer associated with neurological problems, and the Curling's ulcer is a peptic ulcer associated with burns.
I see.
So then there is your immune system. I am very fussy. My burn patient, if it's a biggish burn, they should be nursed in a single room away from anybody else. They shouldn't share a room with somebody who's got tonsillitis, who's got some wound somewhere, with some infection somewhere where they can pass to them. I don't allow flowers to be sent to my burn patient because they could be harboring some, I don't know, insect and bacteria and whatever. Okay, because they may be yes. So so burn patients are immune suppressed. I don't usually start antibiotic, but if you look after the burn wound properly, then they don't get infected if you look after properly. So it's because of this that most GPs I know will automatically, and most A&Es I know will automatically start them on antibiotic, which is wrong. Okay, wrong. No antibiotic. Okay, so it covers everything. This is just a slide that tells you it affects your muscle, your kidneys, your brain, your heart, your lungs, your liver, your immune system. Okay, and of course, your skin. Okay, so the other thing you should do is give them your tetanus if they've not had it, your ulcer prophylaxis, and usually if it's a big burn, I would put in an NG tube because their stomach goes into stasis, and any food that is in there, they might vomit it, and you don't want them to risk aspirating. So an NG tube goes in. Then because they cannot eat the amount of food that they need because their basal metabolic rate goes up 3 times. So you can give them a lot of ice cream, you can give them high calorie food, but they still will lose weight usually. So you put in, usually in a burn unit, a nasojejunal tube that you can feed them with, and a nasogastric tube to suck out anything that they cannot absorb to prevent aspiration. Okay, so there's 2 tubes in place. Okay, so I don't usually clean with antiseptics except the first time. I don't usually give antibiotics at all. And I don't usually, okay, now the blisters depends. So something like this, which is on the palm or the sole where they are thick, if they don't cause a problem, don't break it yet. Don't prick it, because then you're breaking the layer that protects you from infection. Okay, usually if they come to me and I'm going to do a definitive dressing, I will break it. But if it's on the, let's say, the surface of the skin where the skin is very thin and it's like half broken already, then you can. But otherwise, it works as its own biological dressing temporarily until you get to a burn unit. Okay. So now this is the main bit, okay? The wound care, where it's mostly dressings. Most burns, because most burns are partial thickness burns, they can heal with dressings alone. They don't need surgery usually, okay? And it's very important to start the rehab phase, and it's very important to talk about scar care as well. So temporarily, if let's say you've had a burn, and like some people, they're very good, they wash and wash and wash and wash in the shower, then what do you cover them with? If you put something like a towel, that towel will stick to the burn area, and every time you go to a GP, you lift that off, it hurts. Then you come to A&E, the MO lifts it off, it hurts. Then they call me and I come and look at it, you open it and it hurts. It's worse if you go, let's say, to university hospital where the houseman looks at it. No, the A&E person looks at it, the houseman looks at it, the MO looks at it, then the reg looks at it, then the consultant comes in and looks at it. Whereas if you use something like this, a cling film, which is temporary, and inside of it is relatively sterile and clean, you just put around, you take a micropore tape or something to just hold it so it doesn't slide off and doesn't roll off. And then on top of that, you either put a towel or a blanket, and then you transport the patient. So it immediately relieves the pain because it is covered. But you know, when you remove your towel, it doesn't hurt because the cling film is there. So, and you can view and you can look at it, and everyone can look at it, and it doesn't hurt. So this is how I temporarily dress my patients in A&E if I'm going to be going to theatre that night. Let's say a child comes in, you have to wait for them to be fasted, and I'm going to do a definitive dressing. I will temporarily put this, and then I will hold it in place with a crepe bandage or whatever, and then we'll wait, send them to the ward and wait for OT, and then I'll do the definitive dressing.
Oh,
They're all...
this is what you use for food and all, right?
Yep.
Oh.
Our A&E has it, okay, because I made sure they had it.
Okay.
Okay, so it's very, very useful, extremely useful. Temporary dressing. You don't waste money, don't waste with gelinet and stuff like that. You just use this, wrap around. I'm not asking you to go and wrap round and round and round like wrapping
Or-
chicken like that.
No,
but
no,
just
like wrapping
one layer.
the luggage, you know, at
Yeah,
that.
yeah. Don't wrap like that, please. Please don't wrap like that. You just overlap a little bit so it doesn't immediately fall off. Hold that joint in place with a little piece of micropore tape, and that's it. Fine, done. Okay. And so definitive dressing. There are all sorts of dressings out there in the market. There is none which is right, which is wrong. It depends on what you have available, what the patient can afford. Because like in some, like, clinic kesihatan or some district hospital, maybe all you have is paraffin gauze, so it's not wrong. It is good. And if you do your dressings well, then the burn will heal. What you're doing is supporting the burn, protecting the wound until the patient heals themselves. So you are just doing protection. Okay, so there's adherent, not adherent dressings, things like Mepitel, which is more expensive. It really doesn't stick. Whereas the Gelinet, if you don't scrape all the oil with it, it will stick. Okay, and then there's Tegaderm. I once accidentally burnt myself with an iron when I was in the UK and living in a bedsit, and I didn't have a ironing board, so I ironed on the bed, and the iron tipped over and touched me on the arm. So of course I immediately washed it in the sink for 20 minutes. Believe me, 20 minutes is a very long time. And I had a little small piece of Tegaderm like that. I put it on, I dried it, I put it on, and that was it. It lasted me 10 days. I didn't remove it. 10 days, I could go to work, I could scrub up, I could operate. 10 days, I remove it, all healed.
Oh, was that the time that you already became a plastic surgeon, or?
Yeah. I was doing a fellowship. Yeah.
I see. So that was not what made you become a plastic.
No. So then there are other dressings like hydrocolloids, which is like duoderm. I know one of the other colleagues in Sunway loves this. It's not wrong either. You can put this on, it works. Then there's alginates like Caltostat. Okay, and then there's the hydrofiber like Aquacel AG. Okay, and then there's these other dressings. There's this one called Aquacel AG Burn. It's a bit like Aquacel AG Extra. It's a bit thinner. They make it hand-shaped as well, and they come in different sizes, so you can just put it on, because hand dressings are so difficult. But I've moved on now to this other one, and there are many other dressings. I'm sure there are many others that I don't know about even in the market, but this is what I have. And I love this because I can put this dressing on in OT after I've given it a good clean, and then I secure this with something like a sterile hyperfix, and then I put a secondary dressing on, and I can leave this for 2 weeks. So anything that I think is a superficial partial thickness burn, like a child with a scald, I do this dressing and I leave it for 2 weeks. At the end of 2 weeks, I open this and it's healed. It's great. Fantastic.
When you put this dressing, right, you don't have to like stick like a plaster.
Oh, you have to mask.
right?
You must stick. Do not trust patients, okay? They will take your dressing off. They'll say, oh, it was itchy. Oh, it got, don't trust anybody. Okay, so there.
You should have told me a long time ago before I got married. Okay, go on.
So lots of GPs have this. It's silver sulfadiazine. It is really good. I also got this for my other burn, and it's very nice and cooling and soothing. Okay.
You
and
burn yourself just to try all this dressing?
No, I didn't. I was so unfortunate. I got this burn when I was working in a burn unit.
Okay.
But the problem with silver sulfadiazine is that it stains the skin. So if, let's say, you're the GP and you are going to refer to a hospital, but temporarily you want to use this, if you're not going to refer for 2 days, don't use this. Okay, use something like Gelanet or Melalin or something else, because it will stain the skin and I won't be able to tell the depth. So I won't know how to manage this, because if let's say it's actually a deep partial thickness, then I might as well excise and skin graft straight away to not waste time in, you know, waiting 2 weeks. Oh, it doesn't heal. Oh, 3 weeks, it doesn't heal. And then put them through an operation. I might as well, when they come in to me, just cut it out and skin graft. Okay, but not everybody wants an operation. Then there's, say, other things that you can use: liquid paraffin, CMC ointment, chloramphenicol ointment, the stuff that ophthalmologists use if you scrape your eye or something like that. It's very good if you have a burn to a face. Okay, it's just antibacterial.
But
And
they're
then
so small, the ointment tubes.
yeah, I know exactly, which is why I prefer this. This is moist exposed burn ointment. And it is actually a traditional Chinese medicine, half traditional Chinese medicine, developed there, and has herbs, about 3 types of herbs. And it is carried in beeswax and sesame oil. So it smells like chicken rice, but it really stimulates your skin to regenerate. So it's very good for healing burns. But you've got to use it correctly and not chin-chai use, because if you chin-chai use, it doesn't work. And then you go, oh, useless, it doesn't work. That Dr. Margaret was lying, but you've got to use it correctly. Okay.
And what's the correct method then?
Okay, expose method, it is a layer of this meebo, and every 4 hours, you have to wipe it off and put a fresh layer of meebo. But you mustn't let it dry out. So if you put a layer, let's say on your face, and you accidentally, you know, knocked it off, and there's a patch that is dry, you have to reapply and another little bit. It has to be moist all the time.
And this meebo, can it be used for other things like aesthetic?
If let's say you've had laser,
Mm-hmm.
so it is a bit like a burn, right? Because you've taken the top layer off, then yes, you can use it as well.
I see. Okay.
Okay. But you've got to use it correctly lah. I find that in general, expose method is not as effective as a dressing, wrapping it up a dressing. Somehow in Malaysia, it's so humid, and then it's always oozy, and then it slides off, and then you've got it everywhere, and the smell is everywhere. I tried this once when I was working in UM, a patient with the burn, and she was nursed in a single room all to herself, and we did this expose method. I tell you, the entire room, the cabinet, the beds, everything, because she would accidentally drip on her hand, and her hand would touch something, and it was just everywhere. Ayo.
Something of
So
chicken rice.
yeah.
You feel hungry every time you visit her, don't you?
After a while, you get fed up of it. But so it's easier to control if you wrap it up. Easier to control, I find. In Malaysia, it just works better that way.
Okay.
Then you need your secondary dressing. So the reason why I mentioned this is because you remember when we're talking about cardiovascular pathophysiology, in a burn, your cells move apart from one another, so that in between you ooze a lot of fluid out. So that's why in a burn, it's very oozy. You're losing a lot of fluid, which is why they need fluid resuscitation. And your cells will eventually move back together after about the 3rd to 4th day. So then it will become less oozy, and then you don't need to resuscitate anymore. So you need a lot of this outer layer that will absorb the fluid, because if you just put a thin layer and you ooze completely through your Gamgee layer and your crepe bandage layer, and you're lying on a bed and it's in the hospital, you know, Pseudomonas is everywhere. And that's why a lot of burns get infected with Pseudomonas. Okay. So it depends what, I mean, obviously I can't wrap with Gamgee if it's a fur burn to the face, okay? I can't go around like a mummy. So it really depends on where it is, or if it's a genitalia, your vagina or something like that. It really impossible to do this, okay? So it really depends on other factors. So these are the secondary dressings that you use to absorb the fluid, and the other thing to hold your secondary dressing in place, okay? Now, when you're doing a dressing, you need to make sure it is large enough and that it doesn't move. Look at this picture I took of this man who had a head bandage. And you can see from the pajamas that it was from PPUM, where they did the dressing on this man and it did nothing because it just slid off his head, okay, because of the shape of the head. And also, so you need to put it something like this where it's not going to move, or something like an ankle. Again, if you don't do it properly, it will just slide off because of the shape and because of movement, and it will be exposed, and the wound will be exposed and it'll become deeper, and then there'll be more pain. Our thigh is an inverse cylinder shape, correct or not?
True.
So obviously, when you stand up, gravity is going to pull and it's going to fall down, correct or not? It's an inverted cone, correct?
That's why you
So
don't
a
wear
lot
the
of people,
stocking.
when they do a dressing, they don't do it properly. The moment the patient stands up, the dressing already jatuh. Okay, they haven't even walked out of A&E yet. So for those of you nurses out there or doctors who do dressings, just be careful how you do dressings, okay? You've got to make sure it goes beyond, way beyond the wound, and you've got to hold it in place. You've got to secure it properly. Okay, now,
Okay.
of course, I'm a surgeon. I like to cut. So there are some burns that cannot heal with just dressings alone. It can, but sometimes there is can't. Like you can see this, it's a full thickness burn down to bone. Okay, this was an epileptic
Bone.
man who had a fit and he fell against his radiator. Okay,
Wow.
and because he lived on his own, no one knew that he had a fit. And when he woke up, and because it was full thickness burn, he doesn't have any pain. He didn't realize he had a burn. He just got up and did his own thing. And then people wondered why he was so smelly, because it got infected. Then he came in like this. Okay.
Oh my God.
So most deep burns, if it's deep and needs surgery, it should be done early after the resuscitation period. And then after that, careful dressing. Okay. So you need to start rehabilitation. This is an actual patient of mine who had burn managed by a general surgeon in another hospital somewhere. They treated it, but it took a long time to heal and then referred to me for pressure garment. A little bit late. Burn should be healed within 2 to 3 weeks. A superficial partial thickness burn will heal within 2 weeks. And a mixed that will heal within 3 weeks. If it heals beyond that, you're going to get bad hypertrophic scars. The patient's going to have pain, going to be itchy, and they're going to be raised and thick. And it's going to contract down. It's going to cause contractures and deformity and loss of motion. Okay. So they need to go into a pressure garment ASAP. Okay. And usually, if I have a big burn, I refer to occupational therapy, physiotherapy immediately so that they can start moving the patient, preventing muscle loss, contractures, deformity. Okay, really important. Function is so important. It should be there straight away. If a patient is burned to the neck, I always take the pillow away. I never give them a pillow, because if it's in the front of the neck, you give them a pillow, it becomes like this. They're going to end up contracted. So you take away the pillow so they have to stretch. Okay, so physio, occupational therapy, exercises, splinting, positioning, pressure garments for scar care. Okay, so something like this where the scar has contracted down, so they're going to need an operation to release this. If this had been maybe earlier splintered, exercise a bit more, maybe preventable, but sometimes not all scars you can prevent contractures. Some of them are just so bad that it will contract. You're going to need surgery anyway. Okay, so scar care is really important. You're gonna need moisturize, massage, sunblock, silicone gel. Okay, and this is a pressure garment example, and these are examples of silicone gel. Sometimes you need secondary surgery, so a contracture. You usually wait until the scars mature, but sometimes if it affects function, then you do it to prevent an eye exposure, exposure keratitis and blindness. And so you release this with a Z-plasty and only need to graft this bit. So first aid, very important. Okay, you need to prevent burn. You need to prevent complication. Okay, you want the burn to heal as fast as possible. So first aid to cool the burn so it doesn't become from a superficial partial thickness to a deeper partial thickness, because if you wash it immediately, you push it all the way down. Okay, back to superficial partial thickness. Prevent loss of function, prevent deformity, prevent surgery. Okay. If anybody's got questions, you don't have that much time. Sorry.
No, I'm fine. We're doing great on timing. Okay, hold on. I want to share the e-cert
Okay, so
registration
I
form.
stop share.
Ah, yes, you can stop share. Okay, hold on. Meeting room. Okay. So I'm sharing the e-cert registration form for the nurses on Facebook, and then I just shared the CPD registration form for the doctors. So please register, and then we will do it manually because there's no more QR code. So you can also do that. Are there any questions? It's been a very interesting talk, but I don't think many people are, even myself, I mean, I've no experience with treating burn whatsoever. But we do have a question by from Dr. Chok from Doquity. Will immediate local application of systemic steroid be useful in stopping or reducing the progress of burn?
Steroid is an anti-inflammatory. Okay, so you're going to just reduce inflammation. Okay. But you need a bit of inflammation to heal, isn't it? So I don't think it's any good. I mean, if a steroid cream is all you have in your house, after first aid, you can temporarily cover it with that to prevent it getting dried out or something like that. But I don't think you should put that. No. You know?
I don't think that the steroid is an option because
Yeah,
yeah,
it's
it will slow
anti-inflammatory
down,
and
yeah,
you need inflammation to
it
heal,
will
a
slow
little bit
down
of
healing.
inflammation.
Yeah. Okay, how do you actually prevent, okay, infection other than your covering up? Okay, how many % of burn patient actually will eventually get infection? One, and the other thing is this contracture.
Okay,
Mm.
contracture. Okay, so you know, I think it depends on how you manage the burn. So do you know there was this bombing in Bali,
Okay,
and
yes.
half the patients got sent away elsewhere because they couldn't handle the number of burn patients, the number of burn victims. So some of them went to Singapore, some went to Jakarta, some went to Australia. And the Australians did a study and they swabbed every single one of them within the first 24 hours and they grew nothing. So it's only later that you get commensals that become a problem because of the immune suppression. Now, I think if you treated it properly, you managed it properly, and you didn't let it get infected, didn't let your dressing get wet and let infection from outside go through and go in, and you kept it clean, you don't need any antibiotics. I think in Malaysia, I would say probably 80 to 90% of burns get infected, I would say. But, you know, I think if you manage it properly, you don't need antibiotics. I managed a 30% burn in Sunway and I didn't give him any antibiotic. And he was in ICU and he healed, went to the ward and went home. And he's back at work. So it is possible. It is possible. You just have to be very, very careful. You have to make sure your urine catheter comes out fast enough, your extra IV lines come out fast enough, that you don't put in long lines and leave there for a long time. There are lots and lots of things that can be done to prevent infection. You just have to be really, really vigilant and really careful.
Okay, Dr. Yong from Doquity asked, can we use MEBO plus burn shield together for superficial or partial thickness burn?
Okay, burn shield, I think, is mainly just to cool it. Okay, so you use your burn shield and you leave it there until your burn shield is not cool anymore. And then you can put a second burn shield if it's still within, I don't know, 2 hours even. Okay, because actually, serendipitously, I had 2 patients come in at the same time. There were 2 housemates. They got burnt from a stove. And of course, I dealt with the bigger one first. And the smaller one, I just told them to just keep washing. And then when she got too cold from washing, I just said put a cold towel over that area because it was just an arm, and just kept changing that cold towel every 10 to 15 minutes. And her burn actually became smaller in size, you know. So because I spent so much time on the other girl, I only dealt with her like 2 hours later. I think, and I'm sorry to say, I haven't done a study, and I don't know whether there are studies to see if you continue your first aid and your burn shield for 2 hours, whether it really would reduce the size of the burn. But I think it does. So use your burn shield, use your cooling, whatever. Cool. After that, use MEBO. MEBO is so fussy that it will not accept anything else to affect its, how you say, how the herbs stimulate your regenerative cells, your stem cells, to regenerate into skin. It's really fussy. That's what I was taught by the guy that came from China.
You know, there is a towel that when you wet it, it's really, really cold. Have you come across that towel?
No, I've not. I wouldn't
Oh,
mind hearing about it.
I send it. I give it to you.
Yeah. That'll be great,
Okay.
because
My daughter bought it from Korea for me. Apparently, when it's wet, it's really cold. I've never tried it. Anyway,
Okay.
I will
It sounds like something everyone should have in the house, and you know.
Yeah, I can't give it to you. But wait, I'll see. I'll give. I never tried. She gave it to me when she bought it from Korea, and apparently when people go hiking or whatever, okay, they put the so it keeps them. But
okay.
It a bit cramp my style, I must.
Yeah.
Yeah. So the other thing I want to ask you is, you
Yes.
know, there are some countries where there are a lot of acid burns because they pour
Yes.
acid at
Yes.
the woman. Is it the same?
Yes.
The same also.
So the acid burn, especially if you've been burn thrown to the face, just wash with copious amount of water. Now the problem is, in these poor areas, it's the woman who carries the water from the well in the house, isn't it, to wash. This not, you know, we are very, very lucky. We live in Malaysia. We have access to taps, and the temperature of the water coming from a tap in general, unless you know it was out in the sun and it's very hot when you first turn it on, is the perfect temperature. It's about 20 something degrees, and it's not too cold. It's not like in UK where you freeze your hand just trying to wash your face in the morning. It's really the perfect temperature just to cool the burn without becoming hypothermic. It really is. It's excellent. You know, so just wash, cold tap. And let's say you don't want to waste water, you know, climate change. You know, if it's somewhere
I think when it comes to this kind of situation, it's not the time to think about climate
change. So you just
change.
dunk in a bucket of water, you know, if it's a hand or a foot or something like that, you just dunk in a bucket of water.
If somebody throws acid at me, I won't be thinking of climate change. I will be thinking of revenge. Okay, Dr. Swaran asked, what about the use of safrotol? Is it safrotol?
Safrotol. I'm not sure what safrotol is, but it sounds a bit like paraffin gauze, I think it's fine. You know, any dressing that doesn't stick and you can remove and change and protects the wound and allows the patient to heal themselves, that's fine.
Okay. I think we won't take any more questions. I will go and find the thing and let you try it. Maybe you can try it on burn patients. Oh, that would be.
By the time they come to me, it's a bit late. We should send it out to all the GPs.
Oh, yeah, yeah.
Tell them that they should have it there, and
Oh,
maybe
yeah.
send it out to schools,
Oh,
and
I
have
don't
it in
know
the
how much
first
it
aid
is.
box.
Oh, I don't know. I need to find out. I don't know. I never used it, but my daughter bought it when she went to Korea, and she asked me to try it, but I've just left it there.
Okay, all right.
Okay.
Thanks
Thank
so
you,
much.
everybody. Thank you. It
Thank
was
you.
very good talk. I really enjoyed it. And as usual, I learned quite a lot because I haven't done anything but cardiology for the longest time. And thank you, everybody who didn't go to Coldplay concert and decided to come to this webinar. I see you next week. Next week. I can't remember what we have next week, but I'll see you next week, every Wednesday until.
Oh, Dr.
Yeah.
Jeffrey is giving talk on reconstructive work.
Oh, next week?
Yeah, that's what you told me. I don't know.
Oh, I think
so.
next week, hold on. Next week is, yes, it is. It's Jeffrey.
Yeah.
Oh, yes,
So
Jeffrey.
so
Okay, so
that's what I do with him. You know, our 18 hours, 20
yeah,
hours.
so we will look at what they put in for reconstruction work, which they do quite a lot actually, yeah.
I don't know about a lot lah. It's just
quite
that it's very satisfying, you know, when it works. It's just so satisfying. It really is. This is why I went into medicine. This is why I went into plastic surgery, you know.
satisfying, to her. She likes to torture herself. 13,
It's
14
not that I like
hours.
to torture myself. I like the outcome at the end where you have, you know, healed a person and they can be whole again.
Okay, but 13 to 14 hours. Oh my God.
No, 18 hours. 18
18
hours.
hours. If I do an complex angioplasty and it's more than an hour, I'm like, okay, never mind. Okay, see you guys. Bye,
Okay, bye.
everybody. See you tomorrow.
Okay, see you tomorrow. Bye.
Bye.